Whether it was step 1, step 2 CK or step 3, behavioral questions remain one of the most challenging questions on the USMLE exams for most medical students. In this video, we will take you through the high-yield concepts of the behavioral questions that are commonly tested on the USMLE exams, which can serve as the preparation for you to start studying and as a review at the end of your preparation. Now let's switch to Ethan, who is a medical student at the University of Miami and one of our amazing tutors on our website, thematchguy.com, and he scored amazingly both on step 1 and step 2 CK. And he will take us through the most high-yield concepts that are tested on the USMLE exams for behavioral questions.
Hi everyone, my name is Ethan, and today we're going to be talking about some high-yield concepts in the behavioral sciences for the USMLE exams. So with that, let's get started. Our first topic is child abuse, and there are certain signs to look out for child abuse. So these could take the form of burns, especially those that spare the flexural creases, because when children are dunked into hot water, they can usually flex their limbs and spare the flexural areas. The next is bruises, fractures, and there are certain kinds of fractures to be on the lookout for. These include sternal fractures, scapular fractures, posterior rib fractures, metaphyseal fractures, so corner or bucket handle fractures as they're called, and spinous process fractures. All of these, what they have in common is that if children are grabbed and shaken very roughly, that can lead to fractures in those areas. Next, we have malnourishment. Then we have STDs in young children. Of course, children should not have STDs, or if children display any knowledge of sexual practices that they otherwise should not know, that's a red flag for child abuse. Another sign is an inconsistent story. So let's say the mom says one thing and the dad says another. That wouldn't really make sense. Also, if the mechanism of injury is inconsistent with the child's milestones, that's a red flag as well. Let's say the mom has a 1-month-old and says that the child got injured from falling down the stairs. That wouldn't make sense because a 1-month-old wouldn't be crawling. So that's something to keep in mind as well. Another one is late presentation. So if a child comes into the office a couple of days after an injury, that probably wouldn't be something a normal parent would do. And lastly, we have behavioral changes. So let's say a child was previously doing well in school, had good grades, didn't really act out, was behaved at home, and now suddenly the child's grades are falling. He or she is getting into fights, maybe, otherwise just having behavioral changes that weren't there before. All of those are red flags for child abuse. And then there's some relevant epidemiology. So, of note, physical abuse is commonly in children under 1 year old. It's actually most common in that population. It's around 40% of overall cases, and 80% of child victims of emotional abuse have a psychiatric illness by age 1. So how do you handle this? Do you inform the parents? Absolutely not. What you do is you contact Child Protective Services, and that's if you even suspect child abuse. If you're wrong, it's okay, but physicians are mandated reporters of child and elderly abuse, which we'll talk about in a bit. So yes, you always report child abuse. Next, we have elder abuse. So certain signs to look out for. So burns as before, bruises as before, fractures as before. All of these are non-specific, but they should make you potentially think of elder abuse in the back of your mind. Malnourishment, behavioral changes. So let's say that an elderly individual is now exhibiting behaviors that he or she did not have for his entire life. That could be a sign of elder abuse. And then we have medical changes. So let's say a elderly individual had previously controlled hypertension, and in the context of other behavioral changes and maybe some new bruises or burns, they come to the office and they have a blood pressure of 150/90. That would be pretty suspicious, right? Because their blood pressure was previously controlled. And it's possible that the caretaker is withholding the medication from them. So do you report elder abuse? As with children, absolutely. So physicians are mandated reporters of child and elder abuse if they even suspect it. Again, you must report this. Even if you are wrong, it is okay. Next, we have spousal abuse. So again, certain signs to look out for. Do you report spousal abuse? So this is the interesting thing. With spousal abuse, you actually do not have to report it. This is because, in theory, children and elders might not be able to vouch for themselves, and you have to report it. But for an adult who otherwise has the capacity to do so, you do not have to report. However, there are still ways to handle this. So one of the main things to do is to develop something called a safety plan. So for a safety plan, what that is basically helping the patient identify people and places that can provide help during a crisis, somewhere they can go for help if things ever get especially bad with their partner, and overall just helping them make their environment safe. You never want to guilt the patient into leaving the relationship, because the patient's already experiencing a lot of distress, and that could just make things worse. Next, we have the patient interview. So what kinds of questions do you ask for the patient interview? What you want to do is ask open-ended questions to evaluate them further. So let's say a patient comes into the office and they're not taking their medication for whatever reason. Would you want to ask something like, "Oh, Mr. Smith, are you not taking your medication because you're afraid of the side effects?" Or would you want to ask, "Mr. Smith, why are you not taking your medication? Tell me more about that." You probably would pick the second one, right? Because it's more open-ended and you can get the patient to tell you more about what's concerning them at this time. Also, if someone else is in the room with the patient, you always want to interview them alone. That can be because the patient might want to say things that they don't want their family or friends to hear and only want to tell their doctor, essentially. So it's always important to give them that space to be able to voice their concerns confidentially. Next, we come to the topic of interpreters, which the USMLE exam loves to test. So the ideal setting for using an interpreter is in person, just because it's the most fluid. It basically helps you establish rapport with the patient as naturally as possible in the setting of an otherwise pretty substantial language barrier. Now, what do you do if the patient has a bilingual family member who offers to interpret? So in this scenario, unless it's an emergency, the answer is no. And why is that? That's because with the family member interpreting, they could interject their own biases into the conversation and potentially change the nuances of what either the physician or the patient is saying. So you would not want to use a member of the family or a friend for that reason. So given all of that, you do want to use available resources. So for instance, a lot of hospitals have telephone interpretation services where you could connect to an interpreter and use them as if they were in the room with you. But of course, if you do have an emergency, then you can use whatever is available, including a family member who offers to interpret. That is because in that scenario, it is the only method of communication you have with the patient, and at that point, the need to communicate with the patient supersedes all else. Emotional relationships with patients. So if it's a psychiatrist, if it's current or former, it is always unethical. That is because the psychiatric patients can often be at risk and, given their mental state, might not make the choices that are best for them. So for a psychiatrist, it is always unethical to have a relationship with their patients. If it's a current physician besides psychiatrist, then it's unethical. If it's a former physician, there's debate about that, but for the USMLE exams, it's always safest to select the choice that says do not date the patient no matter what. If it's the parent of a child, perhaps maybe it's a pediatrician taking care of a child, in that case, you might want to consider transferring the care just to make sure the child gets the care that they need. But again, for the sake of the USMLE, you probably would want to put something like do not date the patient or the parent because this could compromise care. Demanding or rude patients. So patients can be unfortunately demanding or rude. And it's important to recognize that despite this, all of them deserve the same empathy as any kind of patient. So there's the example on the USMLE exams of a patient who comes in past business hours demanding immediate care. So in that case, what do? The main thing you have to do is set boundaries. So explain about the specific business hours and the reasons for why patients can only come in these hours and why the patient cannot come after these hours. The patient cannot just show up every day unless they have an emergency. It can compromise the care of other patients, and overall, you just have to be firm with the patient and explain why it is inappropriate. As before, you could use open-ended questions to ask why they keep coming in after business hours and doing things that might be considered inappropriate. This can help you establish rapport with the patient and just sort of tap into what exactly they desire from their medical care. Treatment of friends and family. So it is not recommended unless you have an emergency. As before, with the situation of the interpreter, this is because there's a lot of biases that could come into play when treating friends and family, and it's just generally not the best thing to do. It's important to understand the several reasons for this. So one is favoritism. Let's say you have a physician and the physician has lots of patients and he is related to some of those patients. The other patients might feel that he is giving the patients that he's related to special treatment, and that would be unethical. Even if he's not doing that, it could still appear that way, and you wouldn't want to give that image off to your other patients. Next, we have a big one, which is patients not disclosing important information. So let's say you have a surgeon and he's treating someone who he's related to, and they're doing the preoperative clearance, and that person, the patient, doesn't want to tell the surgeon that she is a smoker because she doesn't want the surgeon to judge her. Maybe it's her brother or her uncle, and she doesn't want her family to judge her for having a smoking habit. That can be problematic because if she's an active smoker and goes into surgery, that can lead to some pretty bad complications. So you want to make sure that the patients feel like they can give any sort of objective information without risk of judgment, and that risk of judgment can be heightened with having friends or family as patients. So those are just some reasons why treating friends and family is usually not the best option. Of course, if you have an emergency and you are the only medical professional around, then it's warranted. Reporting doctors. So unfortunately, doctors can be or can make some pretty bad choices, and there are a couple of reasons you might want to report doctors. So let's say they are impaired with drugs or alcohol. Let's say they are doing unsafe practices for patients. Maybe they are conducting an experiment of some sort that's unethical. Maybe it doesn't have IRB approval. Maybe it's just causing danger to patients. That's another reason to report doctors. Next, we have if the doctors are sexually harassing their patients and making them feel uncomfortable. All of these are valid reasons for reporting a doctor. If it's a resident, you probably want to report them to the program director or the chair of the hospital or department. For attendings, you could report them to the chair of the department or hospital, Otherwise, you also could report them to the designated health committee or the local supervising personnel. There's also the option of reporting them to the state licensing board. And as I was saying before, it's important to report doctors who are compromising the care of patients. The USMLE exams want you guys to recognize that the safety of the patient is the highest priority. So if the patient is put at danger for any reason, you do want to report the doctor. Next, we come to informed consent. So there's a couple of components of informed consent. So disclosure. Has the patient stated a choice themselves? Do they have the capacity to have informed consent? So do they understand the nuances of what they are choosing? Are they in the right state of mind to make a pretty serious choice? And lastly, is it voluntary? Is the patient making this choice on their own? Are they making it under pressure from someone else? If they are, that's not the best thing. The informed consent process should be the responsibility of the patient and the patient alone, so they can decide what they feel most comfortable with. So when you're doing informed consent, you have to discuss the risks, the benefits, and the alternative treatments. That way, the patient has a full picture of the landscape of their options and can make the best choice for them. Now, what if the patient can't give consent? What if it's an emergency? What if they are in a state of psychosis, delirium, they're intoxicated, they're manic, or they just otherwise have no capacity? In that case, you probably would want to look for a surrogate of some sort. That surrogate would make the decisions on the patient's behalf and would effectively try to act as if they were the patient. They should be someone who knows the patient well, and they should make the choice based on what the patient would want, not what they themselves would want, which is a very high yield point for the USMLE exams. Now, let's say a patient is refusing treatment. So is it a question of decision-making capacity? So if that's the case, you want to assess them. You want to make sure that they have the capacity to make a choice and understand what they are choosing. It's also important to note the difference between consent and assent. So consent is given by an adult and assent is given by a minor under age 18. Lastly, we have capacity versus competence. So capacity is decided in the medical setting by a healthcare professional. Meanwhile, competence is determined in a court of law. For informed consent, as before, you want to make sure the patient understands the benefits, the risks, and the other treatments that are possible, because when they are refusing treatment and going against medical advice, that can potentially and most likely lead to some pretty adverse effects. So they have to understand the benefits and risks of what they are doing, especially the risks. If yes, and the patient can give informed consent, you have to respect the patient's wishes. This is their choice, and ultimately, you as the healthcare provider are there to guide them, but not to make the choice for them. If they cannot give informed consent, in that case, you would want to search for the guardian who could help make the choice on their behalf. Next, we come to the case of the Jehovah's Witness. So there's a very typical scenario for the USMLE exams, and in that case, you have an adult who comes to the ED after experiencing a car crash or some sort of trauma, and they're bleeding out. And you ask them, can I give you a blood transfusion? And they say, no, I'm a Jehovah's Witness. I don't accept blood. What do? As before, it is the patient's choice. This goes against their religious beliefs because Jehovah's Witnesses do not believe in taking blood donations from others, so you cannot give them blood if they are refusing it. However, if it is a child in that case and the parents are Jehovah's Witnesses, and they are saying, do not give the child blood because it goes against our religion, in that case, you would still give blood. And why is that? That's because parents cannot deny a child life-saving care, and you have to make sure you're doing everything for the child to keep them alive. Once they turn 18, it's a different story. They can make their own choice. But until then, they are especially under the care of the medical team, and you have to do everything possible to act in their best interest. If the patient is unconscious, you can consider reaching out to any family or friends who knows the patient well, and that might give you a clue into what exactly is permissible versus not permissible in terms of the treatment of the patient. Also, you can give other treatments to Jehovah's Witnesses who are denying blood. So, for instance, you can give them EPO to increase their red blood cell production. You also could give them IV fluids to help stabilize them and their blood pressure. So there are other things you can do, but it's important to note that for a Jehovah's Witness, you do not give them a blood transfusion if that's what they say. This all comes back to the theme of doing what the patient wants and that the patient has their own autonomy. HIV disclosure. So let's say you have an HIV positive patient who does not want the physician to disclose the diagnosis to their partner. What do you do? So the first thing to do is to encourage the patient to have a discussion with the partner and to disclose the diagnosis. It's important to note that the physician should say all of the reasons for this and should be realistic with the patient in terms of what might happen as a result. But the patient should be encouraged to definitely disclose the diagnosis on their own. If they don't want to, then the physician will have to do something else about that. Namely, the thing that they're going to have to do is talk to a local health department. So all 50 states and the District of Columbia require healthcare providers to report new cases of AIDS to their state health departments, and many states require that for HIV too. What the health department will do is that they will eventually contact the partner and let them know that they are potentially at danger of contracting HIV or AIDS, but the physician themselves, notably, cannot subvert the patient's wishes. The physician cannot contact the partner and tell them that they can potentially get HIV or AIDS from the patient. That is completely inappropriate, and it's important to recognize that the physician has to go through certain avenues in order to protect the public health, while also maintaining the physician-patient relationship. Next, we have minors and parental consent. So, of course, parental consent is ideal. If the parents aren't there, then the healthcare providers can call. Let's say you have a child who's in the hospital and needs to get a dose of pain medication. In that case, you might want to call the parents just to make sure that the parents are okay with the child getting the medication. Of note, grandparents can't consent for children that they are not guardians for. This all comes back to the idea of the parents being the legal guardians and being able to make the choice for the children. If you are in an emergency, let's say you have a child who's in an accident and comes to the ED and needs immediate surgery, in that case, as with the Jehovah's Witness, it's up to the healthcare system to do whatever possible to keep the child alive and act in the child's best interest. So it would be permissible to do whatever they have to do to stabilize the patient, whether that be certain medications or taking the patient to the OR or anything like that. Lastly, patients have the right to deny vaccines for kids, but they can't prevent life-saving treatment. Vaccines versus life-saving treatment, it's a bit of a nuanced topic, but ultimately, the topic of vaccination is up to the parents, and for life-saving treatment, which can encompass other things like having to go to the OR after an accident, parents cannot prevent this. Next, we come to consent for minors. So consent is not needed for certain topics. These include STI treatment, birth control requests, pregnancy, substance abuse, mental health issues, and if the patient is legally emancipated. So what all of these have in common is that they are pretty touchy subjects for the patient, and they should not necessarily involve the parent because, again, they are pretty touchy topics, and that can lead to some infighting and drama in the home. So if a 16-year-old comes to the office requesting birth control, you do not have to ask the parents if it's okay to prescribe it. You can just go ahead and give it. Also, if the parent asks, is my daughter taking birth control, you cannot tell the parent about that. That falls under the realm of the child deciding what they want to do on their own, and you should not tell the parent. Also, I mentioned that word emancipated. So what exactly does that mean? So if the child is married, if they're in the military, or otherwise financially independent, this all places the child basically in the position of an adult. It shows that they maybe have their responsibility to care for themselves and that consent usually is not needed. There's also discourse about whether having a child yourself emancipates you if you're under 18, but for the STEP exams, the main ones to focus on are marriage, military, and financial independence. HIPAA and privacy. So HIPAA specifically involves identifiable information. There's a typical scenario of doctors in a packed elevator who want to discuss the care of a patient. What do? Ideally, they should not discuss the care of a patient in a setting where others could hear about it and identify who the patient is. In a perfect world, the doctors would discuss it outside the elevator, away from people. If they do have to, they should make it as de-identified as possible and not list any kind of information that can be used to track down the patient. Now, let's say that a woman is visiting a clinic for whatever reason, and the husband calls the clinic and says, I know that my wife is a patient there. Can you tell me about XYZ? What medications is she taking, etc.? So what should the clinic say? What they should say is, we cannot confirm nor deny that she is a patient here. It might seem a little bit extreme because the husband did say, I know she is a patient there, but that doesn't matter. Ultimately, it's the wife's permission to talk to the husband that matters, and if she hasn't given the express consent, then the clinic can't even confirm whether or not she's being seen there. What if an employer asks about the health status of a patient? So, talking about the health status of an employee to an employer can be a little bit serious because that can potentially lead to the employee being fired if they are not healthy enough to do the job. So the most important thing is to see if the employee has given consent for the healthcare system to talk about their healthcare status with the employer. If they have, then the healthcare system can give only what's absolutely necessary to answer the questions of the employer. Sending pictures over text should never be done. Text is not a secure pathway for discussing patient care. You should always be using an encrypted software or messaging system in order to share patient data, in order to prevent any kind of leak of information. Lastly, we have the example of a doctor who notices that he or she has a family member or a friend in the hospital, but he's not their doctor. He just notices that they're in the hospital, and he wants to know why they're in the hospital. What do they come for? Is it wrong for this patient to go into the electronic medical record, the EMR, and look at the info? Absolutely, the physician should not do this. That is an invasion of privacy and can result in very serious consequences. It compromises the patient's privacy and should absolutely never be done. Next, we come to disclosing information to employers and family members. So again, only if authorized, the patient has the final say in whether information can be shared with family and friends and employers. HIPAA has a minimum necessary standard, which means that you can share information if allowed by the patient, but only the absolute minimum necessary to answer the questions of whoever is asking. This helps answer questions while also protecting patient privacy. Now, let's say you have a patient who has violent intentions. So, if the patient is posing physical harm to themselves or to others, you have to disclose this to the authorities. So, there's the case of Tarasoff versus California, which happened a couple of decades ago. And in this case, there was a psychiatrist working with the patient. And the patient said, "I'm going to kill my girlfriend or ex-girlfriend." And the psychiatrist, wanting to preserve the privacy of the patient, didn't say anything. What happened was the patient actually did go ahead with that and did commit murder. That led to the duty to warn clause. So if a patient says that they are going to kill someone or hurt someone, you do have to warn whoever that person is, and also alert the authorities. If the patient has expressed a plan for how they are going to hurt themselves or others, you also could consider involuntary hospitalization just until the patient is back at a point where they are no longer a threat to those around them. Research on vulnerable populations. So what exactly is a vulnerable population? These include prisoners, ill people, ethnic minorities, and non-English speakers. And what these populations all have in common is that they all could be potentially taken advantage of. They all could be forced maybe into some sort of coercion, into doing something that they otherwise wouldn't want to do, but they rather feel like they kind of have to do it. The same standards apply as elsewhere with research, like getting an IRB, for instance, but there are additional precautions that you have to take, and this prevents the issue of the patients feeling like they are coerced into having to do this research. Let's say you have a patient who is in a coma. So the main focus is on what the patient would have wanted. So the first thing you are going to look for is an advance directive. That's an oral or a written will stating what the patient would have wanted if he or she knew that they were going to be in this situation in the future. So, do I want to be kept on a ventilator versus not? That kind of thing. Then we come to a durable power of attorney. So this term means, did the patient assign someone in the past, it could be anyone they know, to make a decision for them in the case that they are in a coma? Ideally, it should be someone the patient knows well, but if the patient themselves has designated someone, this is your point person for figuring out what to do. If there is no durable power of attorney, what you want to do is look for a surrogate. And there's a very particular order that you want to do this in. So first you look for the spouse, then the adult children, then parents, then the adult siblings. And all of these people should be using substituted judgment, essentially substituting their judgment for what the patient would want and making the choice based on what the patient would want. If there's no agreement and there's no surrogate, so there's no spouse, there's no adult children, and so on, in that case, you would invoke the Hospital Ethics Committee. So the USMLE writers put the Ethics Committee as a choice for many questions. It is almost always incorrect. So what you want to do is only pick the Hospital Ethics Committee choice, and usually this kind of case where there's someone in a coma and there's truly no surrogate and no agreement can be made regarding what to do with their care. Now, let's say end-of-life care comes up on your exam. So what is DNR? That means do not resuscitate. So DNR means that no CPR, so no chest compressions, cardiac drugs, or placement of a breathing tube should be done. A DNI means do not intubate. So that means chest compressions and cardiac drugs can be used, but you should not place a breathing tube. If a patient has a DNR or DNI, they can still get treatment like chemo, radiation, pain meds, etc. But they should not get the interventions that we just spoke about, depending on their code status, which is related to the DNR and the DNI. Opioids and end-of-life care is a big topic as well. At the end of life, the main priority is comfort of the patient. And opioids can help with comfort. The issue is opioids can lead to depression of the breathing system. At the end of life, it's okay to give increasing amounts of opioids, maybe ones that might result in respiratory depression, if that means that it will provide adequate comfort for the patient. Overall, all of these options should be discussed with patients so they can make the most informed decisions possible and have the most autonomy with their end-of-life care. Withholding diagnoses. So there's a typical case on the USMLE exams of a patient with cancer, but someone in their family wants to withhold the diagnosis from the patient. So what do? You ask why. You ask with an open-ended question, why do you want the patient to not know their diagnosis? It's important to note that there are certain cultures that believe that the patient should not know the diagnosis at the end of life in order to basically protect them from all of the adverse mental health outcomes that can result. But otherwise, you always should ask, why do you not want the patient to know? Usually, however, the patient does have a right to know, and if the member of the family doesn't have an actual reason for it, you should tell the patient. Still, you can withhold a diagnosis if it would pose a danger to the patient or to others, if they would maybe, become violent or try to commit suicide after knowing that they have a terminal illness. It is warranted to withhold the diagnosis until a plan can be developed. Next, we have the topic of hospice. So there are certain criteria for hospice. So you have to stop life-prolonging treatment, so like chemotherapy and radiation, but you can continue palliative care. So any kinds of pain medications that would provide comfort can be continued. Lastly, you need to have a life expectancy of 6 months or less for hospice, or else you are not eligible. Hospice can be inpatient or outpatient. If the patient expresses that they want to be potentially, in their home for the end of their life, you can do outpatient, and you can have a nurse visit every so often to provide the comfort that they would need. It's important just to give the patient a range of options for their hospice and to make sure that they meet the criteria for it before enrolling them in hospice. Next, we have the topic of medical errors. So when a mistake affects the patient, you have to inform the patient. So let's say you gave a patient a wrong dosage of a medication. Even if nothing happened, you do have to tell the patient that you gave the wrong dosage because it did happen to them, and it's the right thing to do objectively and ethically. Also, you always have to inform the hospital administration. There is something called a near miss. So you don't have to inform the patient in a near miss, which is when a mistake almost happens, but then you or someone notice it at the last second and intervene. So you don't have to inform the patient of that because nothing actually happened, but you do have to inform the hospital. And that's because the hospital in the future can work to figure out what led to that situation, what conditions were in place to potentially lead to that error, and they can stop it down the line. And finally, we come to our core principles of medicine. So our first one is autonomy. So what exactly is autonomy? Autonomy, like we've been saying, is the ability of the patient to decide their own medical care. So let's say the patient has a terminal illness and wants to withhold all sorts of life-prolonging treatments. That's okay. It's the patient's choice, and they have the autonomy to make the choice for their own care. Next, we have beneficence. So that is essentially doing what's in the patient's best interest. Let's say you have a patient who needs some sort of intervention, and you have two options. First option is something long, painful, and costly. Second one is shorter, cheaper, and painless. What do? Of course, you pick the shorter, cheaper, and painless one, assuming that the outcomes are similar. Overall, you want to act in the patient's best interest and do what is best for them. It wouldn't make sense to do a sort of intervention that's, costly and painful if a better option exists. Next, we have non-maleficence, and there's a good example from the AMA about this. So non-maleficence essentially means do no harm. And the AMA's example is of a patient who requests amputation of a healthy leg. So why would you potentially go ahead with that operation? It will lead to a significant deformity, it will reduce quality of life, and if it's a healthy leg and there's no real reason to do it, you probably shouldn't go ahead and do that, right? That would be an example of doing harm to a patient, which should never be done, of course. So non-maleficence means do no harm, and the example of a patient who wants the healthy leg removed can be kept in the back of your mind. And finally, we have justice. So justice means that you have to treat patients equally without regard to race, gender, sexual orientation, religion, and so on. So an example of that is you have the ability to treat two types of patients, and you can give potentially a better intervention to someone who shares your race or gender, and an inferior intervention to someone who is different. That is ethically problematic and should not be done. You should be treating patients all at the same level and making sure that patients get the best care possible. So thank you all for listening. I hope this was helpful. If you have any questions, feel free to reach out.
That brings us to the end of this video about the high-yield concepts of behavioral questions that are tested on the USMLE exams. If you're interested in learning about the biostatistics part of the USMLE exams, which is another challenging part of these exams, make sure to check out our course, which will cover in details the concepts that are commonly tested on these exams. As all our courses, the course is 100% refundable if you're not satisfied, and you can check the reviews of prior students who took part in this course. If you have any questions about the behavioral questions or the biostatistics part of the USMLE exams, make sure to leave them in the comments below, or feel free to reach out to me on Instagram or Twitter at Malki Assad, my Facebook page Malki Assad MD, or our email info@thematchguy.com. If you find any value in this video, make sure to hit the like button, subscribe to the channel, and hit the bell sign so you get notified whenever I post future videos on my YouTube channel. Thank you everyone so much for watching, and see you in future videos.